during the descendant of the testes into the scrotum, what's happening there? Before the testes descend, it needs a cushion. بتاع مخدة to absorb, shock absorber. So at that time, what's happened? The peritoneum precedes the testes. بسبقه البريتونيوم نفسه راح نحكي عنه and descends down into the scrotum. Once it descends down, it starts to what? To obliterate. Okay, at that point, and to separate. So part of peritoneum remain down in the scrotum. Okay, acting as a cushion. So when the testes descend, it will go over it. Okay. This part, remaining part of peritoneum, we call it tunica vaginalis. However, the part that connects this tunica vaginalis with peritoneum in the abdomen, the canal here, we call it processus vaginalis. This now should be obliterated and resolved so that it will separate a complete sac down and a complete sac up. The upper sac is peritoneum, the lower one is tunica vaginalis. If it remains, that means the canal is still there. Okay? So that easily any structure covered with peritoneum can pass with it. However, it's not a must to have processus vaginalis to have an indirect hernia. The direct inguinal hernia now, what's happened here, instead of, as I told you, of passing through the deep inguinal ring, then downward into the outside of the abdominal cavity, the structure of peritoneum usually penetrates directly through the superficial inguinal ring, from down straight. Okay? So it's usually located medial to the inferior epigastric artery. Okay? Because you know that we studied the inferior epigastric in the previous lecture. حكينا من وين بيطلع؟ From the external iliac artery. النقطة الثانية حكينا it passes medial to the deep inguinal ring, and this is a landmark, important landmark for us. It's medial to the deep inguinal ring. Then it penetrates what? Transversalis fascia to come and ascends between transversalis and rectus abdominis. At the level of arcuate ligament now, or arcuate line, it will enter into the rectus sheath. Okay? Now the direct hernia, instead of the intestine to pass through the deep ring, all the way down, through superficial ring into the scrotum, part of intestine will penetrate directly here, through this triangular area. Okay? Directly through the superficial inguinal ring. And at this time, because it's carrying a transversalis fascia with it, it does not get actually into the scrotum. It just bulges outside in the direct. In the indirect, as it passes with the spermatic cord, it usually goes into the scrotum. Okay? So if you see a common bulge superior above the inguinal ligament, it's indicating a direct rather than indirect. Okay? A direct inguinal hernia. It happens mostly in this triangle, which we call it the inguinal triangle. Inguinal triangle is bounded laterally by inferior epigastric artery, medially by the rectus abdominis, and inferiorly by the inguinal ligament. Okay? It does not enter the scrotum as you see, it's just bulging outside in the abdominal wall. Now this one is more common in old men because of their weak musculature. Okay? So the muscles become very loose, very weak, so easily the intestine can pass here instead of taking an indirect way. So direct in old people, the indirect in youngs and children. This is your landmark. This is very important. This is just to show you as a landmark. If you look to the inguinal ligament now, okay, above the inguinal ligament, you have the inferior epigastric artery. Now, lateral to it, the deep inguinal ring, as you see, with the vas deferens and testicular vessels passing there. Okay, this is the spermatic cord together. This is your landmark, the inguinal ligament and the inferior epigastric. If the hernia happened here, above the inguinal ligament and medial to the inferior epigastric artery, in which we call it inguinal triangle, it will bulge to the outside. We're looking from inside the abdominal cavity here. So it will bulge to the outside. Okay? This will be a direct inguinal hernia. If the intestine come and enter through this ring above the inguinal ligament and pass down like this, so if it comes, enters and get out like this, it will be what? Indirect. Okay, now if it goes through this opening here, below the inguinal ligament, down into the thigh,
Femoral.
this will be called a femoral hernia now. Because do you remember this opening? This is the femoral ring. I told you the femoral ring is bounded anteriorly by inguinal ligament posteriorly by the pubic bone, medially by the lacunar ligament, and laterally by the femoral vein. Okay, so there is another opening below the inguinal ligament here. If it goes into the thigh, bulging below the inguinal ligament, it would be what? A femoral hernia. Okay? In this view, you can easily see the ligament. You see, this is the inferior epigastric artery. Okay? These are the testicular blood vessels passing through the deep inguinal ring here. Okay? And you can see now a very large opening. You see, look to the neck of the sac. It's very wide. It's not narrow. Okay? It's narrow only if it passes through a narrow foramen, like here. But it forms its own neck or own opening. So it's very wide opening. This is what should be. It's medial and above the inguinal ligament. This is a direct inguinal hernia. The other kind of hernia is the femoral hernia. Now, femoral hernia is a protrusion of abdominal viscera into the femoral canal through the femoral ring, through this opening, which we call it the femoral ring, below the inguinal ligament. This is the inguinal triangle. If the bulge comes here, it's direct. If it passes through this opening, it's indirect inguinal. If it's below here, it's a femoral hernia, and you can easily see it bulging where? Into the thigh, below the level of the inguinal ligament. Okay? This is usually the level of the inguinal ligament. If the bulge was here, it's direct. If it goes into the scrotum, it's indirect. If it's in the anterior medial thigh, like this region, mostly in the anterior thigh, it's a femoral hernia. Femoral is more common where? In females. We said in the previous lecture because of the wider pelvis. Okay? So, inguinal more common when? Females. Femoral more common in females. Usually it's more limited within the canal. Now, because femoral ring is very narrow opening, as I show you here. Okay? It's a very narrow opening. Okay? What's happening if a part of intestine goes during the patient is coughing at once, quickly, okay? So increasing intra-abdominal pressure suddenly, abruptly. So part of intestine can slide down through the femoral ring into the thigh, forming this bulge. However, because the ring here is very narrow, it cannot return back. So this time we call it irreducible. Cannot return back. Irreducible femoral hernia. What we afraid here in these kinds of hernia is that as the intestine passes, as the artery or the arteriole that's supplying this part of intestine can pass out with it. So with the pressure in the femoral ring, because it's very narrow, it can what? Block the blood supply. Okay? It can interfere with the blood supply to that part of intestine. So at this time, the herniated intestine or lobe of intestine will become strangulated. مخنوقة. There is a what? Ischemic necrosis starts happening at that part of the herniated intestine. So this is a very urgent situation where you need to interfere surgically to reduce that hernia. Okay? So femoral hernia can be reducible if it doesn't pass all away through the femoral canal. Okay? Just a small part of intestine. Get out when you cough, out and return back. This is reducible. The most common one, irreducible, once the intestine pass cannot return. And if there is interference with the blood supply to the herniated lobe of intestine, it can be what? Strangulated hernia. Okay? So a strangulated hernia, there is no enough blood supply, which could lead to what? To ischemic necrosis in the herniated lobe of intestine. Year, very old woman, okay, was admitted for incarcerated, which means irreducible, cannot be returned back. Irreducible, okay, but not strangulated. For irreducible, but not strangulated, okay. So there is blood supply, no interference with blood supply. Femoral hernia, okay. Emergency surgical procedure was settled up. So the first thing, the surgeon, look here, cuts through the intestine, through the skin and the superficial fascia, okay, of the thigh. As he cuts, you see this sac here. This is the peritoneal sac covering the herniated intestine. This is the hernia here. can easily sew it. This is the femoral ring, which we spoke, and this is the herniated, okay, loop of intestine within the peritoneal covering of it. And you see that the surgeon can easily pass his finger through the femoral ring. You see this here, this structure here, very thick one. This is the inguinal ligament, okay? So after the herniated sac has been isolated, okay, a small inguinal ligament incision was made. Why? They made a small incision in the inguinal ligament, okay, to facilitate what? The reduction of the hernia, to return it back. I told you, the femoral ring is very narrow, so you cannot return that intestine unless you widen it. You cannot cut the lacunar ligament because it's very small, so it will be very difficult to heal. Okay, you cannot cut the femoral vein. You cannot cut through the pubic bone posterior. The only thing you can cut through is the anterior border of the femoral ring, which is the inguinal ligament. So a small cut in the inguinal ligament to widen the femoral ring. You return it, then you stitch that cut, okay, to prevent it. Or you put a patch sometimes. So this is the inguinal ligament, has been isolated as you see. Okay, and look, he is doing a cut in the inguinal ligament now. You see how whitish the fibers? Now, when the femoral ring is widened, the hernia can very easily reduced. He reduced the hernia back into the abdominal cavity. Okay? Now, to prevent the herniation again, what he should do, the femoral vein is isolated here, very important, to demonstrate that it's absolutely not harmed, okay, or injured. So the femoral vein is isolated only to what? To demonstrate it has been absolutely not involved during the procedure. So there is no injury in the femoral vein. You want to make sure there is no bleeding. This is the femoral vein here. Proceeded ventral batch, ruqa, batch, okay, is used usually as a device to what? To block the femoral ring now, so that it will prevent, because actually femoral ring in vital persons, in viva, the femoral ring is covered by what? By extraperitoneal fat, okay, which we call it usually the femoral bulb or plug, which is plugged, okay, by fat, adipose tissue. So he puts a patch to prevent the reherniation again, okay? The patch has two belts. He has to stitch these belts with the adjacent fascia. He looked for, so medially there is something important here called pectineus muscle, covered with a deep fascia, okay? He will stitch it with the pectineal fascia, and superiorly he can stitch it to the inguinal ligament itself. He makes sure that the patch is covering the whole femoral ring. Simply placed in the preperitoneal space, extraperitoneal. Gentle traction is made just to make sure it will not split, okay, or slide down. Small stitches to the pectineus muscle and to the inguinal ligament. This is stitching with the inguinal ligament. The extra part of the belts will be cut later on. And that's it. What he should do now, he will just stitch the superficial fascia, then again stitch the skin back. this is the femoral hernia. So we spoke about the diaphragmatic hernia, inguinal hernia, femoral hernia. What about umbilical hernia? Okay, umbilical hernia is 3 different types. The most common you're going to see is the congenital one. So congenital at birth. Okay, so the congenital umbilical hernia during fetal life. See, intrauterine life. Okay, it's happened because of failure of the midgut to return back into the abdominal cavity by the 10th week. So what's happened during development in the 8th week of intestine, the liver is very large. So most of abdominal cavity is filled with the liver. So there is no space for intestine to grow up. What they do, they go forward, okay, within the umbilicus, okay, or umbilical cord, let's say. The umbilical cord widen, the intestine go there and grow up there. At the age of 10 weeks, when the abdominal cavity is large enough, these intestines will return back, okay? However, what's happened, if it's failed to return back, they will still outside, okay? And sometimes it's very large, the liver go out, okay, with them, and remain there. So the hernia at this time is physiological, okay, because it's happened for the growth. However, after the 10th week, if these structures, mainly the intestine, didn't return back, it becomes abnormal, not physiological, okay? It becomes pathological, and we call it a congenital umbilical hernia. So congenital umbilical hernia is failure of midgut to return back during the 8th week of fetal development. At this stage, this congenital umbilical hernia, we usually call it omphalocele. I will write it for you. So you see here, the baby born and very large part of the liver herniated outside of his abdomen and covered by peritoneum, by the way, a transparent glistening membrane. We call it peritoneum. See the intestine on the other side, you can see the liver. This is the umbilical cord. So this is omphalocele, or what we call it, congenital umbilical hernia. Several organs herniated outside of the abdominal wall of the fetus. This is called omphalocele. So the congenital umbilical hernia, you can write that it's also called omphalocele, okay? Sac in the umbilicus. Omphalocele, sac in the umbilicus. So that's what does it mean. Now sometimes another kind of hernia happened after birth. It's acquired, so it's not congenital. Acquired infantile in the infants. So what's the difference between infant and fetus? Embryo. When? Yes. So first 8 weeks during the development of organs, you don't have systems yet. It's embryonic life, embryo. After 8 weeks, it's fetus until birth. After birth, as long as he is unable to speak. That's what does infant means. Unable. Fans speak. So unable to speak until the end of the first year. But before that, there is a neonate. First 28 days after birth, we call him neonate. Okay? It's still not accommodated with the external environment, with the new environment he is in. If he accommodates and lives, the neonates now become infant. So we have embryo, fetus, neonate, infant. After the infant, after the first year, when the child starts to speak, he's a child. Okay? He's a child. Infant. So during the first year, or specifically a few months after birth, when the child starts to cry very hard, pushing on himself, because when he cries, he's increasing intra-abdominal pressure. The mother will notice that the area of umbilicus is what? Is bulging, as long as he is crying. When he is relaxed, it returns back down again. Okay? This is what we call it acquired infantile hernia, okay, or umbilical hernia. This is because of weakness in the scar formation of the umbilicus. The scar is collagen fibers, or the fibers, okay, that form connective tissue fibers around the umbilicus to close it, to obliterate it. Because you know it's open during what? Fetal life. It's umbilical vein, okay, and umbilical arteries, umbilical cord. Once you cut inside the body, okay, now these structures will start to obliterate, replaced by connective tissue, and they close. If there is a weakness in the formation of these fibers, okay, not complete formation of the scar, okay, of the umbilicus. So that's easily when there's an increase in abdominal pressure, the intestine can go outside through the scar. When it's reduced, they're reduced back again, okay? So it's happened because of weakness, okay, due to weakness in the scar of the umbilicus, in the fibers that forming or obliterating the umbilical cord inside the body. So this is called acquired infantile umbilical hernia. Small hernia in children due to weakness in the scar of the umbilicus. Only when the child cries or coughs, okay, it can go and get back, so it's reducible. Usually it does not being treated because with growth, more collagen fibers will form and they will obliterate it eventually, okay? So it heals by itself as the child grows up, okay? The other one, or the third one, is the acquired umbilical hernia of adults, not of a child, as you see. Very prominent, okay? It does not protrude through abdominal scar. It's not through, because at the adults, the abdominal scar now is completely, the umbilical scar is completely obliterated. What's happened, it's usually due to weakness in linea alba, okay? The weakness in linea alba, whether above or below the umbilicus, okay? Most of the time it's above, so it goes through linea alba in the umbilical region, okay? So once he is walking, and it's not reducible, it will remain there, okay? Because the linea alba tears, actually. There is a tear in linea alba, so the intestine can easily go out through it. So it will become very prominent like this. We call it acquired umbilical hernia of the adults, or para-umbilical hernia, because to indicate what? It's not in the umbilicus. It's a tear in linea alba, okay? 3 different kinds. The last kind of hernia you will see is the lumbar hernia, very rare. However, if you see it, okay, it occurs through which we call it Petit's triangle or lumbar triangle, which is a weak area in the posterior abdominal wall, okay? The neck of the hernia here is very wide because the triangle is wide and the intestine can go out easily. What is the lumbar triangle? Lumbar triangle, okay, is an area of weakness in the posterolateral abdominal wall, as you see it here. This is the lumbar triangle, where there is no enough muscles to cover, okay? Anteriorly, laterally, let's say this muscle is the external oblique, which will goes down, okay, into the iliac crest. Behind this large muscle, which is the broadest muscle in your body, أكثر muscle flattening or covering areas in your body, which is the latissimus dorsi muscle, okay? And inferiorly, the iliac crest. So in this area, you will see that anteriorly external oblique, posteriorly the latissimus dorsi, inferiorly iliac crest. So there is a weakness area here, okay? Because you remember, I told you, origin of external oblique or insertion of external oblique, it's inserted only on the anterior half of the iliac crest. However, the origin of the internal oblique, anterior 2/3, so it goes a little bit backward, okay? So what's located here actually is the floor of this triangle should be what? The internal oblique muscle, okay? So it's a weakness in the internal oblique muscle. This weakness in the lumbar region and transversus abdominis, of course, and it will lead to what? To herniation of part of intestine to the outside, reducing the lumbar hernia. The last kind of hernia, internal, we will speak about it in the lecture when we speak about peritoneum. Quick view, what's peritoneum? We will continue in the tomorrow, inshallah. You hear this word a lot, peritoneum, okay? So peritoneum is part of which we call it the serous membrane mechanism in your body. What is the serous membrane mechanism? Serous membranes, okay, in your body mechanism is a mechanism that developed by the body to reduce friction of movable organs, okay? Or to reduce friction on organs that in continuous touch with a movable other organ, okay? This is called the serous membranes mechanism. You will see it in the thorax, around the lungs, the pleura, around the heart, the pericardium, okay, in the abdomen, the peritoneum, okay, around the testes, tunica vaginalis. All of these are the serous membranes mechanism, okay? So serous membranes is, in a very simple way, what is that? It's a fluid-filled sac, okay? It's a sac piece filled with the fluid, okay, and covered, okay? We close it. So a fluid-filled sac that covering around the movable organ. This is a movable organ, we cover around it with this sac. Okay? So that to reduce friction. So now the sac will have two layers. One layer of it touching the organ, the other layer is touching the other organ or the wall of the body. So the movement can be very easily because of the presence of a fluid inside the sac. Okay? So this is the serous membrane mechanisms. Okay? It made of small flat cells. Okay? Simple squamous cells. We call them simple squamous mesothelial cells that secrete fluids. They don't secrete a fluid actually. They filtrate a fluid. At these cells which form this sac, there is so much blood capillaries. And at these blood capillaries, the plasma fluid that filtrates to become interstitial fluid will penetrate these cells inside the sac. Once it's inside the sac, it will become the fluid of the sac. So the fluid here is nothing more than the filtrated plasma, okay, of the blood, which is, we call it interstitial fluid, okay? So that's the serous membrane mechanism. So what's serous membrane mechanism? It's a fluid-filled sac covering, okay, movable organs to reduce friction. In the lungs, as they expand, they will touch the thoracic wall, okay? To reduce this friction, we cover them with the serous membrane. We call it pleura. The heart, we cover it with the serous membrane. We call it pericardium. Abdominal organs, we cover them with serous membrane. We call it peritoneum. However, we have so many movable abdominal organs. It's not single here. It's not like the pericardium or the lung. So this sac has to extend and cover first the stomach. We have to stretch it, okay? Okay, expand it and covering the intestine. Then we stretch it and cover the colon, okay? We stretch it further to cover the liver, okay? So this is why they call it peritoneum. Tonium means stretch. Okay? You stretch the sac to cover around so many organs, okay? That's why they think it's a little bit complicated issue because it's not covering only one organ. So what's peritoneum? It's a serous membrane. Serous means a fluid. Membrane that creates a fluid. How? By filtration, okay, of plasma, okay, or interstitial fluid to become the fluid inside the sac. It's a serous membrane of two continuous layers that covering the abdominal organs. All these layers, pleura, peritoneum, pericardium, whatever, I told you they will, once they cover the organ, they will have two layers. The layer covering the viscera or the organ, we will call it visceral layer. The layer which is covering the wall, the parietal. Parietal means wall, okay? The parietal layer. Actually, if you open the sac, they are the same, one layer, continuous with each other, okay? They are continuous with each other. So it's made up of two continuous, the same sac, okay? Layers that covering the abdominal organ. The parietal layer, which will line now what? The internal abdominal wall. The visceral layer, the organ. And in between them, there is a space within the sac, yes? Filled with the peritoneal fluid. We will call it the peritoneal cavity. Okay. So we call it the peritoneal cavity. Now distinguish carefully, please, between the term of peritoneal cavity and abdominal cavity. This is very important. When I speak about the peritoneal cavity, I'm speaking about the space within the sac. It's filled with what? With the fluid only. There is no organs in the peritoneal cavity. Do we agree on this? But in the abdominal cavity, it's the whole cavity surrounded by the abdominal wall, which contains the whole peritoneum and the abdominal organs. Okay? Clear, simple. So distinguish these two terms, abdominal cavity and peritoneum cavity. If you follow this image, if you look to this image, see this black line here? This is the layers of peritoneum, okay? And this is the peritoneal cavity filled with the fluid. So if you look to the sac, it's first covering all around the abdominal wall. So this is the parietal layer, okay, of peritoneum. At a certain area, you see it's now folded to cover around the stomach. So now it is visceral, okay? After it covers the stomach, it goes to cover the spleen. It is visceral. Now returns back to the wall, to the posterior abdominal wall. It's parietal. And you continue, it's completely closed. What's inside here is just fluid, peritoneal cavity filled with the fluid. Now the relation of organs in the abdomen, okay, to the peritoneum is of two kinds. Whether we call it intraperitoneum, but it's a misleading term. It's not inside the peritoneum. Intra means completely covered by peritoneum, from anterior and posterior, okay? Completely covered by the sac, not inside the sac. So intraperitoneum, like the stomach, which is covered anteriorly and posteriorly, okay, by the peritoneum, by the visceral layer of peritoneum, or it could be a retroperitoneal. Retro means behind the peritoneum. So it's only touched anteriorly, okay, by the peritoneum, as in the case of the kidneys. You see here, there is no peritoneum behind in the kidneys. They directly rest on the vertebrae and the 12th rib, okay? So retroperitoneum is behind the peritoneum, so that it's only covered partially or anteriorly by peritoneum, by parietal layer of peritoneum, not the visceral, okay? So two relations of peritoneum. Intraperitoneum, completely covered by the visceral peritoneum. Retroperitoneum, posterior or behind the peritoneum. It's only touched anteriorly by the parietal peritoneum. The peritoneal cavity itself now, if you look to the peritoneal cavity, okay, this is the liver, this space, all of this space in blue is the peritoneal cavity. When we speak about peritoneal cavity now, okay, we divide the peritoneal cavity into two areas. Most of the peritoneal cavity, we refer to it as the greater sac. However, a small area behind the stomach, and it's happened to actually stretched behind the stomach to produce free movement of the stomach, okay, to reduce a friction as the stomach expands. This part of peritoneal cavity expanded behind the stomach here, okay, this is which we will call it the lesser sac, okay. Now, because of so many structures, okay, if this is the stomach, and I want to expand the greater sac, the peritoneal cavity, or behind into the stomach, this is the stomach, here should be what? The liver, covering above and lateral. Below should be the intestine, okay? So there is not enough space to expand the sac. There is only a small opening here. So the sac has to pass first through this small opening, okay? And expand behind the stomach like this. Okay, so this is small opening where the greater sac now, and now we will have the lesser sac. This is like this, okay? So through small opening between structures. This small opening is called the umbilical foramen, or foramen of Winslow, described by Jacob Winslow, a French anatomist. He described this small opening where we take part of peritoneum to stretch it behind the stomach. And that's why this part of peritoneum now we specialize it, because we stretch it behind the stomach. So we call it the lesser sac, okay, of the peritoneal cavity, okay? So what's the peritoneal cavity? It is a greater sac, which is the main part of peritoneal cavity, and the lesser sac, we can see it here. You see it? Dark blue. This is it, the lesser sac, and this is a small opening where we expand the sac through, then widen it, okay? So this is called the umbilical persa or the lesser sac, okay? It's extensional cavity behind the stomach to allow for a free movement in the stomach, okay? It has several recesses. If you look to it, it expands inferiorly. We'll speak about it later on. Inferior recess, another one behind the liver superiorly, superior recess. We will speak about them. It connects with the greater sac through which we call it epiploic foramen, which is this one. This is the opening where we take the sac and expand it like this here. Okay, so this is the epiploic or umbilical foramen or foramen of Winslow. Okay, this is another review. This is the greater sac, كلها, the peritoneum cavity. Okay, surrounding the liver, the intestine, whatever. Now here, a small opening, foramen of Winslow, where we expand a smaller sac behind the stomach. This is the lesser sac. Okay? This is a diaphragmatic view, an illustration for the epiploic foramen. You see it? This is the epiploic foramen. Foramen of Winslow, which connects the lesser sac behind with all this region, the greater sac. We are within the greater sac. We cut the parietal peritoneum and we inside the peritoneal cavity here. Okay? So this opening here is the foramen of Winslow, the omental foramen, the epiploic foramen. It's bounded anteriorly by a small structure. We call it the portal triad. Okay? It's bounded anteriorly, as you see, by the portal triad. What is the portal triad? It's three vital structures that go into the liver. Actually, portal triad, if you remember from one lecture I told you, it is the root of the liver. Any organ should have a hilum, opening, and root. The root of the liver is the structures that enter or leave the liver. Three structures. The portal vein enters the liver for blood filtration. Hepatic artery enters the liver for oxygenation of hepatocytes. And bile duct leaves the liver to carry the bile secretion from the liver. Okay? Three structures, we call them the root of the liver, or we call them the portal triad. Okay? ثلاثي البابي. Because they get through the portus of the liver, liver. This is the portal triad. So very vital structures at the anterior aspect of foramen of Winslow. Behind, there is a large vein, you see? شو هاي? The inferior vena cava. Okay. So IVC behind, portal triad anteriorly. What is superiorly? This part. This is the liver. Okay? Specifically the caudate lobe of the liver. Inferiorly this. Stomach ends and starting this part. It's the first part of duodenum. The first part of the duodenum. So inferiorly duodenum, superiorly the liver. Anteriorly here should be the portal triad, and behind, you cannot see it, should be what? The inferior vena cava. This is the greater sac, as you see, and this is the lesser sac behind the stomach. This is the foramen of Winslow. IVC behind, portal triad anterior. Duodenum inferior, okay, and should be the liver here superior for the foramen of Winslow, which indicates that this foramen is very crucial because you cannot cut through any boundary of it. You cannot cut the portal triad to widen the foramen. You cannot cut the inferior vena cava to widen this organ, okay? You cannot cut the duodenum or the liver, okay? And what's happened now, sometimes part of intestine, let's go back to the previous lecture, part of intestine can move, okay, through this opening, which is a narrow opening, into the lesser sac. This is another kind of hernia, internal, within the abdominal cavity. So this is which we call it the internal omental hernia. I told you we have 6 different kinds of hernia, okay? The diaphragmatic, inguinal, femoral, umbilical, lumbar, and the last one is this one, the internal omental hernia. Omental because it's passing through the omental foramen of Winslow. So part of intestine can pass into the lesser sac here through this narrow, okay, opening, the foramen of Winslow. We call it internal omental hernia. Next lecture, we will continue, inshallah.
Как посмотрели, ладно?